In 2016, CGD convened a high-level panel on the future of multilateral development banking. And in that report, we called on member governments of the World Bank to reshape the World Bank's mission towards leadership on global public goods as low-income countries grew and the mission and the mandate of the World Bank changed. And pandemic preparedness is one of those key global public goods. So as representatives from donors and borrowing countries prepare to convene for the fourth and final World Bank IDA 19 replenishment meeting in Stockholm, I believe next week, we have an opportunity to deliver a set of messages around what the role of the World Bank and multilateral institutions are in health security, acknowledge gaps and inefficiencies where they exist, and reflect on how we can strengthen and sustain health security in an increasingly interconnected world. We commend the World Bank for the commitments that they've made to global health security. It's in the IDA 19 documents. There's a policy commitment there, and for putting preparedness higher on the agenda. But U.S. leadership in this space is essential, and we'd like to see the U.S. government do more. The Commission report talks about exactly what we'd like to see more of. So with that, it's my pleasure to introduce Steve Morrison. He's Senior Vice President and Director of the Global Health Policy Center at CSIS, and he'll kick us off with a presentation of some of the key messages from the recent report. Thanks.
Hi, and good morning. A special thanks to Amanda and to Bryn Datema for organizing this and hosting us today. And a special thanks to my colleagues, Anna Carroll and Samantha Stroman, who are with us, who did a prodigious amount of work in generating this report, which is available online. And I hope you have an opportunity to look at it. There's an elaborate microsite that is part of this effort too, and we're continuing to add content to that. I'm going to say a few words about the genesis of the Commission and how we operated and why we formed this, and then I'll walk through the recommendations. We put this Commission together in April of 17, following about 5 or 6 months of roundtable consultations that we had begun in the prior fall, where we were reaching out to experts, and we chose 5 key areas of health security, just convening experts from within the executive agencies, from universities, from think tanks, and independent experts, to solicit their advice as we were trying to form up the agenda. We began with this idea after the 16 elections that this was a zone of a zone that merited a lot of increased attention, but it also had the added advantage that it had a pretty strong bipartisan consensus, and it had not been politicized, had not become a toxic zone of policy. Discussion, quite the contrary, was a bit of an oasis of cooperation across party lines and between Congress and the executive branch. And that a lot had happened, and I'll say more about this, both positive and negative in recent years, that we could hook upon. We went and marketed this on the Hill. We enlisted former Senator Kelly Ayotte and former CDC Director Julie Gerberding to co-chair this. They were very enthusiastic and very committed. We enlisted 6 members of Congress, 3 Democrats, 3 Republicans. Those are Senators Murray and Young, Congressman Cole, Brooks, Barra, and Eshoo, and their staff. And then we brought our totals up to 22, and it was a mix of folks from the security domain, from diplomacy, from public health, from the development world. We have with us one of our commissioners you'll hear from today, Jimmy Coker. We also put together a group of 10 experts and asked them to identify with the work of the Commission and contribute their expertise to a number of the deliberations, and Amanda Glassman and Jeremy Konendijk from CGD agreed to take on that role. Carolyn Reynolds, who's affiliated with CSIS as an associate, also took on those responsibilities. In the course of the last year and a half, the Commission met for for 3 formal full sessions, and there were countless other meetings and sessions, both public and private. We issued, I believe it's 15 analytic papers that provided sort of the background, looking at the evidentiary base for arriving at our conclusions. We wanted to arrive at a very strong consensus. Congressman Cole and others were urging us to come up with a meta message and a doctrine of a sort that could be marketed internally within Congress to both parties as a coherent and pragmatic set of actions that hung together that could help guide the discussion. There was a sense when we got started that this was a missing piece, that people talked about different elements, but they didn't talk about a coherent whole. And one of the big appeals that was made at the very opening of the commission from Congressman Cole and echoed by the co-chairs and others were to come up with something like that. I think there was also the direction that we had from our co-chairs and the members of Congress and other members was we did not want to simply come up with a set of findings and recommendations that were a recitation, a revisitation of countless other earlier reports. Obviously, we needed to ground what we did in those other pieces, and nor did they want to see a utopian set of proposals. They wanted to see us pick our spots and show some rigor and discipline in what we came up with. You'll see in the proposals, and as you read through the report, the aggregate cost, budgeted costs, is under $1 billion. If you pull out the proposed increases in the contingency funds, that drops that number by several hundred million. This is a fairly, in budgetary terms, this is for what we're proposing in terms of U.S. leadership, this is a fairly modest proposal, and that's very deliberate. In other words, we wanted to come up with a package that could be marketed as something similar to some of the other foreign aid initiatives of the last 10 years that have tended to be in a fairly modest range of around $1 billion per year in additional commitments. So I mentioned earlier our premise was that health security is a special domain. It's a oasis of bipartisanship. There's been some areas of significant progress, put a special emphasis on the global health security agenda, that there's been an accumulation of evidence, what Amanda referenced, the different studies that were done post-Ebola 2014-15 in West Africa. There were 7 major international studies that were undertaken and a lot of focused analyses after that brought forward quite a bit of new evidence around what the true costs were when there was not preparedness, but also what the true costs of investing in preparedness would look like. We hung the argument on the idea that we were stuck in a cycle of crisis followed by complacency. We began with the argument that we are in a world that is much more dangerous and disordered, and we needed to factor that into all of the thinking around how we define the boundaries of health security and how we prioritize what the U.S. government should be doing. As we get into the discussions today, we're putting a focus on the multilateral financing dimension. We identified the gap of low-income countries and lower middle-income countries not investing in their own health security as one of the most glaring and conspicuous weaknesses, and the absence of any agreed financing architecture that could begin to address that. And it was that in mind that we moved ahead with a special focus on this. We on the downside, of course, we're making the case that health security is indeed national security, but oftentimes it's not matched by the kind of financial and political commitments that are required. It becomes more of a periodic rhetorical commitment, that the investing in preparedness is something that is innately difficult. It competes against more visible pressures for investments. It's difficult to see the results oftentimes. We did not put much focus on animal health in here. We did not put much focus on climate change. We were decidedly focused outside our borders. We make reference to the domestic requirements, but that was not our lead concern. We are in the course now of moving this product forward. We're trying to touch multiple audiences. I'd say our top priority is trying to get these ideas registered on the Hill, but we are going to try to market these ideas to campaigns. We're marketing them to think tanks here, and we were talking earlier about continuing to revisit this as we move forward. This I've already covered. I would say that one thing that was very distinct about this commission was that the members were highly active and gave us quite a bit of time and contribution. And that was, I took a signal of their commitment and their sense that something quite significant could be accomplished in the course of this. So let me just walk through the recommendations. We're going to focus in the panel discussion on the multilateral financing, but it's one of 7 of the core. The first one is to restore security leadership at the White House. The argument is that this is fundamental to our ability to be effective both at home and abroad, and that there is no substitute for this. If you read through the background and the rationale, there was a lot of pressure upon us from within the commission itself to get the facts right and to not make this a partisan argument. And we obviously had to acknowledge the recent progress in the development of policy and the National Biodefense Strategy and other policy formulations that have come out recently. But we stop at arguing that there is no substitute for running an effective interagency and overcoming fragmentation. The appeal that was coming from the co-chairs and others was for greater efficiency and focusing upon the fact that this is a field that's highly fragmented, and that trying to create greater accountability and rigor in the investments that are made across this sector is going to be very important, also in marketing it on the Hill for the higher levels of investment. Also, there's no substitute in responding to crises and in asking for there to be a strategic vision. We have seen these new policy formulations come forward, but there is no budget attached to them. There's no strategic action plan attached to them, and we are trying to move forward from that point. We're also trying to say that if you really believe that global health security is national security, it has to be embodied institutionally in the White House itself for that argument to have credibility. The second is commit to sustained commit to full and sustained multi-year funding for the global health security agenda. This actually turns out to be a pretty modest increment. It's $135 million additional. But we're saying we're at the end of the $1 billion emergency supplemental funding that allowed us to open up these capacity building partnerships principally in 17 countries. But we're now in retreat, and we have to stop that process of retreat and get back on course over a 10-year time frame and make the commitment. The Pandemic Preparedness Challenge, which is the focus today, established a Pandemic Preparedness Challenge at the World Bank to incentivize countries to invest in their own preparedness. I'll say more about that in a moment, but we did publish in April an analytic piece. We pulled a working group together. Tom Frieden from one of our commissioners was highly active on this. Ambassador Coker was quite active. Carolyn was very active in this, as well as Amanda McClellan from Resolve to Save Lives. We wanted to really make very clear that this was the most conspicuous and glaring gap at the moment. The fourth, I'll get back to that in a moment. The fourth is the need to ensure access to resources for health emergencies. We're proposing pretty dramatic increases in the contingency funds at both USAID and CDC at $250 million per year. We're also proposing there be a yearly investment of $25 million in the WHO, the World Health Organization's contingency fund for emergencies, as a way of showing our resolve to operating at that level and getting others to contribute to that fund, which has suffered in this last phase. We are calling for the establishment of a global health crisis corps. Here, I would emphasize that we are making the case that the world has become much more dangerous. Access has deteriorated in multiple emergency crisis zones where outbreaks are centered. It's not just DRC, Eastern Congo, where we have the Ebola outbreak now in its 18th month, where access is critically difficult. It's multiple other cases that we point to. And with that rise of insecurity, we are arguing that our ability to deploy a critically important civilian expertise safely into those environments is now highly impaired, and we find ourselves increasingly on the sidelines. So you're having outbreaks, you're having the destruction of health infrastructure, and we need to rethink what is the risk calculus, what's the risk tolerance that we're willing to live with, and how do we invest in training up teams that can effectively work safely and effectively in these environments. We're not calling for a militarized DoD element. We're calling for building upon existing capacity within CDC and AID, and we go into considerable detail on how we propose for that to happen. I must say that this particular recommendation is one that stirred an enormous amount of discussion and debate. And I was really delighted that, in fact, we landed on a consensus around how it would be, how and why we need this and what it's going to take. Programs in disorder. The sixth recommendation, strengthen delivery of critical health services in disordered settings. This is multiple things. This is calling for heightened attention to how do you protect and ensure the continuity of immunizations in these disordered settings. Secondly, how can we expand our work in gender-based violence? And thirdly, how can we expand the delivery of critically important health services to vulnerable women and young girls in particular? This is these are topics that are typically not treated in health security. They're topics that are treated in humanitarian emergencies. We're making the case that in the current disordered world and increasingly dangerous world, we need to, again, factor this into our thinking about how we operate in these environments. On the tech, systematically confront two urgent technology challenges. There we are talking about building a direct investment relationship and cooperative relationship with CEPI, and I can go into more detail on how we arrived at that and why. But there was an investment made earlier in consulting with CEPI, in examining its work, and making the case that the U.S., now's the time for the U.S. to step forward and develop a strong relationship. We are arguing that in the big picture, we're in the midst of a revolution in the life sciences that is increasingly going to be seen as tied to U.S. national interests in our global competition with China and others. We are calling for much greater attention to antimicrobial resistance and universal flu vaccine. On the public health communications crisis, what we're really talking about is the decline of trust and confidence in vaccines that has contributed to the regression in measles and other disease controls. We just had the WHO report just come out that showed in last year 140,000 deaths worldwide from measles and a massive expansion in cases. This, of course, is rooted in social media. It's weaponized social media. It's rooted in a decline of trust in industry, governments, science. And we have some very concrete proposals there on what needs to happen in terms of a much more deliberate and intentional U.S. policy in this area. We didn't start this process thinking we were going to land with a fairly aggressive set of proposals around addressing vaccine hesitancy. But as we moved through the process, that became much clearer. So this is the recommendation that will be the center of discussion here. I don't want to rob Carolyn and Jimmy the opportunity to sort of walk through what's in it and how do you move this forward. Mukesh Chawla, Tim Evans from the World Bank were very integral to putting this together. As I said, we had a working group in the spring. We published an initial paper. We had a lot of cooperation from Treasury, from Sean Souter and Arjun Viran. We were Tom Frieden and Amanda McClellan, very, very active. The basics are we're calling on the U.S. to exercise leadership in launching a 5-year, $750 million pandemic preparedness challenge. That U.S. contribution would be 20%, 1/5 shares that would require a diplomatic investment to move this forward. The target countries would be the 32 fragile and conflict-affected countries eligible for financing under the International Development Assistance. So we're talking fairly modest dollar investments. We were debating earlier today, is this something that could be done in the immediate action by Congress? We'll hear more from Carolyn on that. We want to signal that this is a way in beginning to crack this. It's one of many possible ways in cracking the code of not having a clear financing strategy for getting countries to invest more, low and middle income countries, to invest more in their own capacities. So with that, I'm going to close and invite our panelists to come on forward. Again, thank you, Amanda. Thank you, Bryn, for welcoming us here today. Did you want this?
You can leave that proposal up there. Actually, Carolyn and I discussed this idea in 2016 when she was at PAC. It was in our 2016 White House and the World report, and it's really, really exciting to see this getting closer to reality. And so let's start with you, Carolyn. You're an associate at CSAS. You've long been engaged in both the World Bank and in global health security issues. Tell us a little bit about this proposal. What's its rationale? Why do we think it would work? What's it going to take to make it happen?
Great. Well, thanks for hosting this, and thank those of you who came out today and who are listening online. As you know, outside today, there's people mobilizing on climate, and I think we will know that we are successfully getting this message heard when we have that kind of action out on the streets on this issue. And I'm really serious about this because this is an issue that does not have enough advocacy and enough energy and enough people actually pushing on this conversation. This is some of us have been, as you say, Amanda, in this discussion for a while, but the circle is still pretty small of people who are focused on this challenge. So I think this report is incredibly important and timely. And this recommendation in particular, I think, deserves some real focus. So Steve walked through the specifics: 5 years, $750 million, challenge fund housed at the World Bank. Why did we think that was a good idea? And a little bit more on the specifics. So why 5 years? 5 years is tied to the global health security agenda, which, for those of you who are not that familiar with it, but is essentially something that the U.S. initiated in 2014, and with U.S. leadership has grown to 70-plus countries that are now members of the global health security agenda, and that list is growing across every geography. And it really has become Jimmy will say more about this, but it's become a diplomatic and a multi-sectoral important forum for engagement around global health security. The U.S. has been a real leader in that, and countries that are part of the GHSA, again, very much with U.S. leadership, signed up to a framework to 2024 to essentially hit several benchmarks on strengthening global health security. So we're tying it to that explicit time frame, which is already a priority, started under the Obama administration, but very much carried forward by the current administration. The U.S. pledging 1/5 of the shares, $750 million total, but $150 million over 5 years, $30 million a year from the U.S., very modest, matching 4-to-1 by other donors. It would fund both capital and operating costs to help the poorest countries, the 32 classified fragile and conflict states that are eligible for IDA funding, to help them implement their pandemic preparedness plans and address, which are basically have been put together, national security action plans, they're also called, have been put together to address the gaps that have been identified in their joint external evaluations. And we can say more about that. And so the goal is that over those 5 years, we're helping those countries move the needle on their scores for the joint external evaluations. And it's things like disease surveillance systems, laboratories, communications, trained epidemiologists, many of those things, which will effectively help to detect, prevent, and respond effectively to outbreaks before they spread. And it specifically is time-bound. It's specifically also, the idea of the framing is a declining share of donor engagement. So these are countries that are not able to fully fund their plans, but over time, over the expectation of 5 years, the share of donor funding would decline. There would be a requirement for at least 20% to begin of the country's investment, and that share of country investment would grow over time. So what's the investment case? Well, we've alluded to a few of those already in the comments from Steve and Amanda, and it is very much that this is a major gap, financing in terms of country preparedness. And not only the Commission report, but the Global Preparedness Monitoring Board and the Global Health Security Index reports, which also came out in recent months, have reaffirmed that issue. These are the countries which are the least able to pay. And they have the weakest health systems, and at the same time, they're facing the greatest risks, and they pose the greatest risks to global health security, because of weak systems of outbreaks spreading out of control, as we've seen in the DRC. These are countries which actually have shown leadership on this issue and country ownership. So we're talking about countries that have gone the step of going through the joint external evaluation process, analyzing their gaps, opening up to the public to say, here are our weaknesses, developing plans around those, but they don't have sufficient funding to cover the costs. And so they have demonstrated that ownership, but the idea of a challenge fund is actually to lean into that and encourage greater leadership, encouraging that ownership of the problem toward the goal of sustainable financing, and sort of essentially helping them get the foundations laid till countries are able to sustain those resources. This is a good use of our multilateral tools, of multilateral financing, and we'll say more about that, but this is a global public good. And yet there's a moral hazard issue because these are countries which have limited resources. They've got many competing problems, not just other health issues, but whether it's education, infrastructure, roads. So to think about investing in an issue which, as we said before, is invisible and you don't see the payoff until there's a crisis, it is tough to make that political case. So the paper that we released earlier in the spring and several of us have discussed, we've got to create different incentives. We've seen that countries are willing to prioritize this issue, but they need to be incentivized to do it, both because it is actually an issue that where the impacts are felt beyond their borders, but also because of competing demands. There's also a burden sharing issue. So that's a good case for a conservative audience, that this is not just about the US taking on some other big, unlimited, massive commitment, but it is time-bound, and it is actually not only burden sharing to encourage other donors to step up, but it's actually pretty modest in that compared to other global funds that we've supported in the past. And the idea of situating it at the World Bank, and both Scott and Mohammed will say more about this, I think is it's a complement to the existing World Bank tools, especially to IDA. IDA's not earmarked. So although IDA, and it's great that there is a policy commitment that is expected to be in the final IDA replenishment to supporting countries in implementing their plans, there's no way to hardwire that. So this actually would act as, if you will, additionality as a top-up, as a way to sweeten the pot, and not compete with their existing countries' existing allocations. It incentivizes them to bring these investments on budget, and also to link them to whole of government, multi-sectoral challenges, which we know are going to be crucial for dealing with pandemic challenges. Similar, for those of you who know the Global Financing Facility, not exactly the same, but similar in the way that works as essentially complement and more flexible than IDA can be. And other tools at the bank that, again, we can talk more about, whether it's the Pandemic Emergency Financing Facility and contingency funding mechanisms, drawdown mechanisms, those are all important, but they're geared towards a response, not preparedness. Finally, I'd just say that, look, this is, I think one thing we need to stress more is it's not just about saving lives, but there's a strong investment case by making these investments to actually avoid eroding development gains that the US and other donors make significant investments in IDA and in bilateral assistance every year. But we saw with West Africa and Ebola in 2014, 2015, what that did to those countries' economies. You just look at Liberia, which prior to the 2014 Ebola outbreak was growing at 8%, one of the fastest growing economies in the world, dipped down into negative territory as a result of that, largely as a result of that outbreak. And only last year did it begin to climb back to 3%. So these are serious, decade-long impacts that major outbreaks can have, and we're trying to avoid that kind of impact in the future. Yeah. We can talk more about next steps.
That's a great point, protecting the development investment as a whole. Now let's turn to Ambassador Kolker. You were a commissioner on the report. You were formerly Assistant Secretary of Global Affairs at the Health and Human Services Department. You've been working on global health security issues for a long time. You've been a partner to developing countries in their development efforts. Can you tell us a little bit about this recommendation, how you see it playing, and what the U.S. role could be?
Sure, thanks. I'm very proud of the report as a commissioner, and it somebody who many of us here are in the sort of policy space of global health security, and this is an opportunity to link emergency response with health system strengthening with actual measurable outcomes. And I think it's rare to have that opportunity, and the congressional members of the commission were actually very precise in saying, we need a roadmap. We agreed to this. It's had bipartisan support. We've been scared and shocked into realizing the cost of inaction. But what can we do in our individual authorization appropriations that can get us to a better place? And I think from that point of view, it's exciting. And as you and Steve have mentioned, the funding part at country level is a huge gap, but one that we have the tools. I mean, we already had in place international health regulations. They're the only mandatory WHO treaty. Countries agreed to this in 2005. Not even 100% of countries report, let alone only about a third of countries actually fulfill a high standard of compliance with the international health regulations. And so we did in 2014 set up Global Health Security Agenda to try to match some effort on developed countries and the way we provide health security assistance, which was up to that point almost entirely through the Department of Defense, how we could move that into the public health arena with CDC and USAID taking equally important roles. And so this recommendation number 3, which is centered at the World Bank from a practitioner's point of view, when I was ambassador in Burkina Faso or in Uganda, the World Bank plays a special role. Their counterparts are the Ministry of Finance. And almost all the other development aid kind of programs have counterparts in the Ministry of Health or occasionally in planning or education. But who has the authority to convene about investments? It really is the Ministry of Finance, and on the multilateral and bilateral donor level, the World Bank. So having them in the driver's seat in this is important. But this also isn't a blank slate. Every country has some capacity. It's not as though we have to define what health security means and have every country start from scratch. You need to know the local situation and to know what they're already investing in, what their sense is of health being only an outlay. This is just an expense to the Treasury and we get no real benefit from it, or is this an investment in a strategy which will bring the country into middle income status or other things? And to be able to see it in that context, you're in a world in which almost all global health donor aid is earmarked. And so the ability for discretionary spending and for spending for things that are important but not urgent is very constricted. And I think that this incentive fund provides a champion, it provides a financial incentive, but also with the World Bank a champion. I think it leverages the US appropriately. The global fund replenishment we've just celebrated does say that the US will only contribute if others contribute more. And that kind of leveraging, I think, was popular with Congress. In fact, Congress was the champion of this, even with some reluctance in the administration. And it's been, I think it's a model which can work politically and certainly can work in practice. And as if you're the US ambassador and you have to go to these endless donor coordination meetings, the question is, are US ambassadors ever instructed to talk about health or health security? Well, almost never. And this, I think, gives us an opportunity to say, yes, the US will be a voice at the table, we'll assume the leadership, which we would have to for this to work, but at the same time, this isn't a US bilateral program. This is something that the country owns through the IDA mechanism, which is very valuable to that country, its Ministry of Finance, and the people who have to make those decisions. And the World Health Organization is extremely valuable in this, and we can get on in a minute to what the US did to help strengthen WHO to play a better role than they did in the Ebola crisis in West Africa, where they failed at every level multiple times. But their total budget for the year for all of the responsibilities that they have is about $4 billion. PEPFAR every year is at $6 billion. UNICEF is at $6 billion. The Global Fund is at $5 billion. The World Health Organization has a huge mandate, but can't be very operational. And I think to expect that this burden is going to be, even with their increased authority for emergency and outbreak mergers, I think to assume that the World Health Organization has the wherewithal at country level to actually lead this process is naive, and that this kind of consortium, which uses an IDA frame of mind to incentivize governments to include their own domestic use, revenue-raising, mobilization of resources, but to give the extra push from international financial community is important. Yeah. I'll just add one more thing in that context. Every country needs to be worried about the Sustainable Development Goals. And Goal 3D sounds beautiful, strengthen the capacity of all countries, in particularly developing countries, for early warning, risk reduction, and management of global health risks. We're all for that. However, there's no indicator to measure that. Those words mean nothing and everything. And the question of how are we going to hold countries to standard and have a measurable result, we do have this mechanism. We have the IHRs, we have GHSA, we have the Joint External Evaluation. And I think by attaching this to improvements on those scores, especially the JEEs, which are very country specific, is a way that we can make that SDG goal actually operational at country level, because just these expressions of good intent this under 3, there are about 7 goals that have numeric indicators, and some of them are quite challenging for countries to meet, which will require a lot of investment. But to then have a vague goal with no indicator, I think means that goal's not going to get priority, and this is a way to give it the priority it deserves.
Yeah, I think that's a very concrete recommendation that could be easily put into place. So now my colleague Scott Morris, he's a senior fellow here and the co-director of the U.S. Development Policy Initiative and the Sustainable Development Financing Program. He's worked at the U.S. Treasury for a long time. He worked on IDA from Treasury, and he continues to watch and monitor the World Bank from CGD. Let me ask you, you were part of this panel on the future of multilateral development banking that looked at the World Bank's ability to support global public goods. What do you see as a good way to do that? How does this proposal of the Pandemic Preparedness Challenge fit with those recommendations and that vision of the World Bank as a global public goods provider?
Sure. I think it fits quite well. I think it's a good proposal. Let me just give a very quick take on the work of our panel at the time and why we reached this conclusion about a central role for global public goods at the World Bank, because, frankly, that is not the bank today. I think the bank has been taking incremental steps toward this kind of agenda, and I'm I'm fairly positive actually about the institution and its ability to support global public goods, but it's a long way from where our panel was going. So our conclusion in that work was based on a couple of things in terms of trends. One is that if you think of the bank's long-standing model, really back to its founding 75 years ago, this was providing country-level support with national governments to pursue their development strategies and agendas. If you think about IDA, which is itself 65 years old, it's focused on the low-income countries. And one of the trends you see with IDA is that there are fewer of those countries today, and there will be fewer still in the future. That, from an institutional perspective, presents a little bit of a challenge, particularly vis-a-vis donors to IDA. You simply ask for less money in the future. That's not where they are today. They are still in a world where each IDA replenishment, the bank works very hard to maximize donor contributions. But that is not inevitable. And I think if it is business as usual, we will see a turn in that trajectory toward fewer donor contributions and less ambition because the traditional demand just won't be there. And in fact, in the last IDA round, we saw, because of some financial innovations within IDA, a very large increase in resources available to a shrinking pool of IDA countries. And that, in fact, creates its own set of challenges under the traditional model. You're allocating quite a lot of lending resources to countries that have challenges in capacity. So that was the one trend we saw. The other was looking at the need to address global public goods and global challenges that don't fit comfortably within these country models that IDA has. And the common strand there, the common feature of what IDA does in supporting national development strategies and the needs of global public goods has to do with the financing. The fact that the nature of global public goods is that they need grant support fundamentally in some form, and that's also the way that IDA operates. It relies heavily on the grant contributions that donors make. So we saw a trajectory going forward where, as traditional demand for IDA resources would decline over time, there would be an opportunity to increase the bank's presence in meeting global challenges and providing global public goods. Climate is typically offered as a leading example, but there are a lot of pressing needs, and this clearly is a compelling one. And I think the experience of it at the bank does point to both that it makes sense to be looking at the World Bank. I think it does deserve some credit for the limited steps it's taken to date on these issues, but it also points to the fact that we are still stuck in a model at the bank that makes it hard to really take on an agenda like this in the core resources. So I think in that context, I think this is a good proposal. I would say that it's the best version of a second best for the World Bank in the sense that it's relatively straightforward to set up a trust fund, the goal of which is to incentivize sort of country decisions around the use of their resources, including their IDA resources. In my mind, the more idealized version of this is that we see an agenda within IDA that prioritizes these issues. Now, yes, there's a tension here. Countries should be in the driver's seats in setting their agendas around the use of IDA funds, keeping in mind in particular that for most countries, these are loans. They are not pure grants. They are heavily subsidized, but nonetheless, they are borrowing for these activities, and on that alone, they should be in the driver's seat. So you can use trust funds to help steer and incentivize on the financing side. But if we could achieve this within the core IDA resources, I think ultimately you achieve some other things. Actually better leverage. So yes, you can have a trust fund where the US is 20%, and that's a lot of work actually to make that happen. I was involved in the creation of one World Bank trust fund when I was in the US Treasury, and it takes a lot of convincing to other donors that your good idea is a good idea that they should support. IDA gives you that on day one, and in fact, I think today the U.S. as a donor is either 10% or less than 10% of all IDA donors. That's quite good leverage to begin with. It also gives you the direct buy-in of the IDA countries, and this is part of the process of the replenishment is making sure that in setting priorities, you have buy-in not just among the donors, but the IDA countries too. And I think, so I think ultimately you can use a trust fund like this in an initial period of years to get that buy-in and then move toward a more sustainable financing model that is in the core of the bank's resources and IDA resources. And I think that would be the path forward on this kind of agenda. And it's consistent, again, as I said, it feels like we're in a transition period at the bank and with IDA in the sense that if you had asked me 10 years ago, my view of set-asides within IDA, so-called earmarks, use different words for these things, I think I would reflect the conventional wisdom is, it's not consistent with the model, these things are problematic. The reality is, I would say nearly a third of IDA resources today are set aside for particular. Now it's a different kind of thing. It's not sectoral for these are things like the regional projects window, the crisis response window, which has played a role on this issue. But that has been the trend, and I think it does reflect a reality of appropriately where IDA should be going over time. So maybe I'll pause there.
Excellent. So we'll watch this space. I like that idea of a phased approach. But now the speaker of the hour, Dr. Mohamed Pate, who leads the health, nutrition, and population practice at the World Bank. Can you reflect, how does this proposal seem to you? Tell us a little bit about the ID-19 policy commitment on global health security and preparedness, and a little bit about the organization of funds currently and what you see are opportunities to improve practice.
Well, thank you. I think, first of all, I'm very delighted to join this conversation, really building on the tremendous work of my predecessor, along with many others that have been mentioned today on this team, and Mukesh and others. I think it's a very vital conversation to have, given where we are, given the fact that we've got infectious disease outbreaks, DRC, Ebola, that's been lingering for more than what we can sort of expect after the West African outbreak, Samoa measles, and all of that. But why are we where we are today? If you're in Goma, or if you're in northern Nigeria, or if you're in Monrovia, why? The weakest link in the chain is actually the lack of basic services available in many of the countries where we operate. And that's behind the lack of trust. It's also exacerbated by conflict and many other issues. So I think acknowledging that and trying to put that at the backdrop of why we are where we are and why these threats are coming on, hundreds of them every year that can escalate, I think we have to acknowledge that. And so back to the question of IDA, the bank's role, multilateral system, but also in the context of the proposal from this commission, I think it's at different levels. IDA and the World Bank have an important role to play in terms of addressing really the underlying determinants for fragility, for also developmental needs of populations. And I think we need to do more in that direction, from a multi-sectoral lens, from the ministries of finance that we work with, but also agriculture and others who have a role to play when we look at the global health security agenda. And IDA is the bank is one of the most important, I think, players that brings all of those elements together, not only health bit. Secondly, the huge investments that IDA provides for the most vulnerable countries in terms of their basic healthcare systems, the primary healthcare systems, to prevent, detect, but also respond. If you're in DRC or if you are in many of the countries that we're talking about, these systems are very important. They are part of the resiliency of health system that is required to move forward on that. And IDA plays a major role in that. Now, with IDA 18, there were commitments to really have the preparedness plans. 25 countries were earmarked, were sort of the target. I think we've got more than 46 countries that have actually prepared their plans, but they're not funded. On the other side, you've got either commitments through the lending pipelines that countries have been investing, more than $1 billion that is currently in the health lending pipeline that is touching on different elements of preparedness, from regional projects, like the REDISE project that we've got in several countries, the East African Public Health Laboratories, and several other projects, in addition to the country-specific lending. So not only do we invest in broader health systems, but also in terms of preparedness in the context of IDA 18. Now, next week, Stockholm will happen, and I think that's an important opportunity to really fully fund IDA 19, to do it very well, because that's really the bigger pie that we can draw in to make faster progress in quality, basic services that will regain the trust of communities when really a crisis emerges, as we've seen in DRC or even in places like Samoa. So that's one element. But there are also important reforms that are really part of the IDA 19 conversations, and I think they've been alluded to in terms of how do we really have an early response CRW, the crisis response window, that enables IDA to play a role when slow onset outbreaks start, before they become major disasters, or within the context of the regional windows, expanded regional windows that countries can draw into. I think those are important, let's say, instruments in the repertoire of instruments that IDA brings to the table. I think Caroline mentioned other instruments like the catastrophic deferred drawdown option, that at the country level, countries can actually have like a credit card to respond on the early stages of an outbreak. But on the broader preparedness agenda, I think it's really about building the health systems, and the recommendation that the Commission has put together is really about incentivizing countries to draw down from their IDA envelopes, the performance-based allocations, and apply them in really solving the preparedness issues, implementing their national action plans. The Global Financing Facility, I think you mentioned it, is one example where a multi-donor trust fund basically has been put together to be additional, to work with the country directors and the regional vice presidents to incentivize investments around broader maternal, newborn, and child health outcomes. And that's one example of a catalytic mechanism. But at the end of the day, the backdrop is IDA. And I think having a successful IDA 19 replenishment is key. But we also, I think, can see this recommendation as complementary. And the US leadership in drawing that is actually very vital. So I think the whole range of instruments and the multilateral system has to really come together. Of course, WHO is a key part of it. Other contingency financing mechanisms are out there, but the bank can play an important role in this as well.
Do you think, thinking of like G7 processes that are coming up, is this something that we could ask as a deliverable from the US government and the other G7 governments this year? It's a low agenda year in some other ways. So what I guess my other question is, how could we galvanize US and other partners' support to such a challenge fund?
I mean, G7 is a great example of where the US did use its leverage to get a commitment. US pledged to help 17 countries,
Right.
And others increased that total to over 75. And they were specific commitments by G7 members to partner with specific countries, in almost all cases where they already had development programs or relationships in health security broadly, but that they were then on paper committed, and they were called on the next year to update how they were doing in those commitments. And I think the report makes very clear reference to the fact that even the US, with its commitment to the 17 countries, has run out of money because this was all under the Ebola Emergency Fund.
Yeah,
and so
exactly.
if our ability to do all of this depends, and there have been lots of developments since then, the Africa CDC, I'd like to just add, because that's one where the US and China are actually both very interested. And when we look at ways that we're competing with China around the world in Africa, ways that here's one where we actually have very complementary ability to help the Africa CDC. And to miss that opportunity because we don't have appropriated funds means that the Chinese can build their building, but the technical expertise that the US uniquely can provide isn't going to be there to fill them, and it's just a huge missed opportunity.
I was going to add to that. So look, global health security was on the G7 and G20 agenda in 2016 and 2017 when Japan and Germany were leading those processes, and so there's a precedent for that. This is an area, I think this would be a terrific initiative for the US leadership of the G7 next year. This is a rare issue in these days where there is not only strong bipartisan support, but where actually US leadership has sustained over successive administrations, and that's been very welcome and galvanizing. And so it's a spot where we can really, there's a strong coalition there already, and I think there would be strong responsiveness from partners. In the context, tying it to the US leadership of the global health security agenda, the global health security strategy that was issued by the White House, seeing this and positioning it as effectively an implementation of that.
Exactly.
And we've already seen, we know that Germany, Japan, the United Kingdom, Finland, well, they're not part of the G7, but Japan, Germany,
European
UK,
Union,
European Union, broader G20, Australia. These are strong champions on these issues that I think would be responsive to a U.S. appeal to come in on a joint initiative.
We did some work looking at a roadmap for the incoming European Commission, and we suggest the challenge fund. So it occurs to me like this is a great opportunity. They're deciding their development spend for the next 7 years, I think. So
right.
this is a good moment, I think, to act. So we have about 10 minutes left. So I'll go to you in the audience. Please, when you're asking a question or making a comment, keep it brief. Tell us who you are, where you're from, and let's go ahead. Anyone? Go ahead.
Hi, I'm Jen.
We're bringing you a microphone because we have people on a webinar.
Hi, I'm Jen Leaphart from the Office of Management and Budget. I was wondering if you could speak a little bit more about the mechanics of the Challenge Fund and how that would work compared to other types of funding, whether it would increase country contributions or what the sort of built-in incentives would be to leverage increased funding.
Okay, let's collect 2 more and then we'll come back to the panel. Others? Go ahead. We're bringing you.
I'm advisor in the Ministry of Finance in Rwanda, working for Development Corporation, German Development Corporation. My question is about the spending amounts involved. In fact, the report by presented by Mr. Morrison is about spending by the US about $1 billion. What is the recommendation from the report, or maybe from the panel, for other countries to spend? I saw a figure that total annual basis, the world should spend $5 billion. Maybe a country should spend $0.3 per capita. So what is the recommendation for countries, say low-income countries, to spend? And then related to that, you mentioned a number of financing facilities. It's all good. There's IDA, of course, through its normal programs, there's GAFI, Global Financing Facility, but yet the amounts are very small. Why not just focus on the technical assistance to countries to get prepared and just ask them to put it in the budget? Put it in the budget is maybe 0.005% of their budget. Even poor countries can afford that. And then just take on the funding need in their overall budget support need, rather than so many funding facilities. Thank you.
Okay, other here at the end.
Hi, Shuan Chai from the Department of Health and Human Services Office of Global Affairs. I have kind of 2 questions. One, you all talk about this challenge, and there's a role for the IDA countries, there's a role for the World Bank and donors. I'd be interested in what you see as the role for other stakeholders, middle-income countries, private sector, et cetera. And related to that, you also describe how this is a 5-year initiative. The hope is that it'll be sustainable after. So interested in how you see this playing into that longer-term plan. Is it a model or, So thank you.
Excellent, thank you very much. So those are excellent questions. Let's turn back to the panel. So our colleague from the Office of Management and Budget asked for some more detail on how it works. Let's start with you, Carolyn, and Jimmy, if you want to add on.
Sure. Well, look, we didn't get into huge detail because this also needs to be. I mean, this is a donor fund that could be shaped in different ways. But the idea was that this does act. I mentioned the Global Financing Facility in a very similar way, a trust fund that is essentially housed at the World Bank and linked to IDA. And so you have a pool of money that is targeted to support countries to invest in preparedness plans. So key qualifications, they have to have a plan in place, and that is costed and funded. That is based on the assessment that they went through at the JEE. So to your point about recommendations of how much countries could spend, I mean, Mohammed may want to say more on that, but I personally would not think that there is a prescribed amount. It's going to be very country specific, depending on their own capabilities and preparedness. There was a point about, why isn't this just, why don't we just sort of, why are we creating a new fund? Why isn't this just sort of integrated into health budgets? Well, I think that would be the goal. The goal for countries would be that this is a priority within their overall national health spend, but we're not there. The incentives are not there for all the reasons that we talked about. So we're trying to actually nudge countries in the right direction to say, if you prioritize this, if you have a plan in place, we'll help you move this along and get this going. And that will not compete with other funds that you have. As your economy grows, the expectation will be this does become prioritized within your national spend. I very much like Scott's suggestion of an on-ramp to this, that this is a way to get it started, but actually over time this is embedded in IDA as a mechanism, which doesn't have to then, it's not an earmark. It's actually for countries that want to prioritize this, here's a special place, here's a window that you can go. It does not have to compete with your country, core country allocation. And as you say, as countries grow and graduate from IDA or become blend countries, the model for IDA funding should evolve, and this makes sense in terms of being able to deal with those plans. So that's a lot in a very short time.
And I think one of the other core ideas, the challenge part of it, it's not just a challenge about money, it's a challenge about progress against the joint external evaluation measures.
That's right. And so there would be measuring against time that actually those scores have gone up.
Yeah, I'll just add one comment that the way this recommendation is phrased is that the U.S. should take some leadership to convene stakeholders in this, convene other donor countries, the World Bank, but also the IDA countries themselves, and figure out how this would work for everyone. So it's not an entitlement. Not every IDA country is going to take advantage of this in our, I think, imagination. But it's something that could give them, it's under the category of how do we incentivize their own spending in this area. And so I think if we presented that on October 1st of every year exactly this mechanism is going to come into place, we'd get no response if we kind of presented this as a done deal. So I think the consultation is an important part of saying, how would this actually work in practice?
And is there, someone asked about the private sector or middle-income country governments, is there a precedent to private sector contributions to a World Bank trust fund?
So the Global Financial Facility, for instance, has sort of pulled together bilateral sources, private sector sources, and also philanthropic capital in a trust fund that is additional, is catalytic to help countries steer towards some important outcomes. But I want to go back to the point about increasing fragmentation or consolidation. I think to the extent that we take the health security agenda and put it in a different box of its own, I think we will not make as much progress as we should. I think it's, when we look at it from the point of view of the basic health systems in countries and embedding the preparedness agenda with it, then we get to countries using their resources in a sustainable manner, and the external financing, multilateral, bilateral, or whatever sources and technical assistance to help them plan, prioritize it, own it, execute around it, and with accountability mechanisms that we can actually track over time. In terms of the estimates, I think there are various estimates out there as to what would be required. One that I saw for the poorest countries is about 5.7 billion that will be required to implement their NAPs. But when you look at it, the NAPs have been in existence. Countries have not funded them, but they've been really investing in other ways as well. So this can be complementary, but it needs to be structured in a way that allows it to plug into national plans as well and link to national budgets. That's the Global Financing Facility model, which has been able to bring in multiple actors in this way, with also an exit over time. Because at the end of the day, you need to really, it needs to land at the country level to maintain it. Global health security, I don't think one country can be able to really, how do I call it, chaperone. It underlies the global solidarity requires countries across actually own it, put their resources and execute around it.
Yeah, and I think the important point about the global financing facility on which this idea is modeled is that it's not a new entity, it's the World Bank. It's IDA, it's part of our existing structures. It's more a
creating
new funding flow.
Yeah, we're not creating a
than-
big new institution. That's right.
Correct.
Yeah.
Well, just in particularly thinking of how this mechanism works, I think it's a couple of things I would note is recognize that it works as an incentive, not a mandate. And in that sense, there is risk of failure here. And I raise that because I would note that health sector advocates are not the first to have gotten wise to the ability to leverage this big pool of IDA money. And a lot of people want to leverage, not everyone wants to be leveraged. And I think that's the challenge for these countries, getting them to respond to the incentives, particularly in what feels increasingly like a noisy landscape in this regard, is that I think the value of this particular proposal is that it intends to be integrated even as a trust fund into the system. I think there are other actors and activities out there that, it's sort of a marketplace for this stuff, is that anybody's free to offer up some grant money to incentivize a country to do something with their IDA money. And I think that's fine, but it is a challenge. And so you have to think strategically about fora like the G7 and the G20 to make sure this is a priority, that it gets that precious word space in the declaration. That does count for something. I think one has to think strategically about how to position this kind of initiative.
If I can add on the resource mobilization, the very good question from the advisor from Rwanda. There were 7 blue ribbon commissions, as you know, and they came up with different figures. I think 5 billion is a good summary. I think in our report, I remember some papers using 4.6 billion as the amount of additional resources that need to be leveraged in addition to what countries are already spending, which again, the metric by which that's measured is a big challenge. The World Bank's pointed out. But the suggestion that we just provide technical assistance and work this into the budget is actually, we've kind of tried that. The US has had an authority to have a global fund for emergencies since 1980. It's been authorized by Congress. It was never funded. HHS never asked for the money, OMB never asked for the money until last year, when suddenly this cycle of panic and neglect, of crisis and complacency, the pendulum swung far enough that we said, unless we put some money into these kinds of funds on a sustainable basis with an incentive to do so up front, that it's not going to happen just in the normal course of events. And I mean, one of the recommendations in the report is for national public health institutes. And I think it's a very small amount of money, but it's really crucial to doing just what you say. What institutions can we set up in low-income countries that would actually be champions for this, would be budgeted, and would identify the country-specific needs and the country resources that could match those, and then figure out what technical assistance. U.S. has a huge comparative advantage in doing that. CDC is the person everyone wants as a partner in this endeavor. But again, CDC didn't even ask for the money to do what we had pledged to do under our 17-country commitment. So the idea that this is going to work just through the normal process of budgeting and the way we manage our own affairs, we've concluded in the report isn't enough. We really have to put up an agenda that has additional kickstarts for some of this.
Yeah, and maybe also to note that the other global health funds do have, including the existing World Bank portfolio, has a really important role to play in supporting global health security for the reasons that you mentioned. But the Gavi replenishment is coming up. It would be absurd to do this and not fully fund Gavi to assure that vaccine preventable diseases are taken care of. And that also, the other issue that worries me is around drug resistance. That is something that does not come through so much because we talk a lot about outbreak preparedness, but that's another, it's met by the same set of interventions, and it's obviously something so important for all of our health systems to use antibiotics more rationally and deal with those kinds of issues as well. Let's go back to the audience. Do we have 2, 3 more questions, comments? You ready to go out and lobby the G7? Okay. Yes, you're getting it.
Prashant Yadav, Center for Global Development. So one of the ideas that was discussed at the time of the Global Health Risk Framework before the PEF was created, and has sort of fallen off, was that if you look at what would convince finance ministry in a country to invest more domestic resources in health system preparedness, it would be if the foreign direct investments are linked to, or the risk and rating agencies, which the FDI investors go out and get a risk rating from, somehow incorporate an element which is linked to the health system preparedness, which would suddenly convince the finance minister that if I don't pay this portion of my budget, then my FDI will be lower, or alternatively, if I go to the bond market globally, then my bond market interest rates will be higher. So any thoughts on opportunities within this to bring back a few things which were discussed pre-PEF, weren't included in PEF in a systematic manner, but may still deserve some meritorious consideration? Thank you.
Yeah, I mean, the more that we get better at the joint external evaluation and the measures included in the JEE, the more likely there is a measure that's in the public domain that could be used in that way.
And the Global Health Security Index is also worth looking at. I mean, that does not have, maybe at this time, the same kind of ownership of countries because it's a new introduction, but it is actually quite comprehensive in terms of the number of countries that they've been able to set a baseline for. And it is incorporating not just information from the JEE, but from a number of different sources. And so, you know, I think that is a very promising, if it can be supported over time, a very promising baseline tool for not just encouraging countries to act, but also to something that advocates can use to build political will.
I think Mohammed and his predecessors deserve a lot of credit for creative thinking around this. While I was still in government after the Ebola outbreak, the World Bank convened meetings about insurance and reinsurance, got the private sector in. This is a very rare, but in a global basis, actuarially predictable event, and the costs are estimable. And so the insurance system of countries being able to buy subsidized insurance to protect themselves from some of the catastrophe is one of the tools that I think we already have. And these other funds are trying to fill these gaps. So I agree with your proposal. And again, the World Bank has been the center of the creative thinking about this.
Yeah, I'll just say that what gets measured gets done. Yeah. So the index, I think, is really a good pathway to that for ministers of finance to see where they rank, but also to really factor that in terms of the risk assessment for FDI for the countries. I think that's a good.
Yeah, I mean, I guess one question that you're implicitly raising, though, is because sort of the trigger for the pandemic emergency facility was not so well defined or difficult to define ex ante. Some have been quite critical of whether it was effective or not. I don't know if you want to talk, Mohammed, about that pandemic emergency facility. Lots of discussion around that, lots of tweeting. What's your thought about how it would fit with this kind of proposal?
Yeah, I think I think several folks contributed in designing it, and I think it's really coming out of 2014, 2015. Suddenly, it was evident that there was need for some mechanism for responding to outbreaks. I think there have been lots of lessons that I think we've learned. We've all been internalizing that. But when you look at the whole repertoire of instruments that are available for responding to outbreaks, they range in gradation, including the crisis response window, for instance, or even the catastrophic deferred drawdown options that can be available. So there are ID instruments that can be valuable, and there's some scope for insurance in some ways. So maybe through the bank, maybe through other institutions. So in Africa, the African Risk Capacity, for instance, is one mechanism that African Union itself has mandated a regional institution, and that countries paid the premiums and able to get some early kick in when a disaster, food insecurity, or now health outbreaks. So I think there's been a lot of learning in the global community in the last 4 or 5 years. And as we forge ahead, I think there's a lot more that we could do to tweak those instruments, including the PEF.
And if I could just add to that, I mean, I personally think a lot of the criticism of the PEF has been unfounded, but the bottom line is that it was the right mode of thinking. We need to do more financial innovation in this space. And to your point, I mean, the private sector sees this as a threat. There's a global health security agenda, has a private sector roundtable that many of the major companies around the world have signed up to because they realize this is a business risk issue for them. The World Economic Forum has built a coalition of actors around this issue. So there is strong private sector recognition of the risks to business continuity, but we need to do, there's a whole opportunity for innovation there. And the way that we've seen innovation in the climate space in terms of whether it's green bonds, whether it's carbon pricing, you can argue, you can debate the merits on all of those, but the fact is we've unleashed a set of financial innovations. We need to do that here.
And maybe with the creation of the new challenge fund, it's a great opportunity to look at the full set of tools on the table and present. The other issue that came up when we were doing the background work for the commission was that there are many quite small funds and sources, and it's actually not so clear even to partner countries what's available, when you would use it, how you would use it.
A great example of that is the international health regulations have a window for countries to help with technical assistance to achieve the IHRs. Up to 2014, they had 0 requests for that help. The whole decade with no one. They had 100 in the next 2 years. And it was way beyond their capacity to do this. So just looking at, as Carolyn was talking about, Mohammed, we don't really need to create new institutions to get this on the table. We need to fund and be able to surge the institutions that we have.
Excellent. So I think the plan is clear. The commission has spoken, and it's now up to us to find ways to move forward. But thanks so much to the panelists and to Steve, and congratulations, CSIS, for a great report. All right, it's a plan.